So good morning, everybody online. Welcome to, is this the first seminar of the year? It might be. Yeah. So we're well into 2025. So I'll just start by acknowledging the traditional owners of the lands where everybody is today. For us, that's the Yagara and Turrbal people, and acknowledge their elders, past, present, and future, and of course, pay our respects to all of our First Nations colleagues who are with us in person this morning. So we've got Carol Hayek, our presenter this morning. I won't steal too much of her thunder. She's going to talk about the Atlas project, which I suppose if you're coming to this seminar, you're aware of what Atlas is. And it really is just an incredible resource and partnership between research and First Nations primary care providers. So it's going to be fantastic just to hear from Carol about where it's at currently and what the plans are for the future. So without further ado, I'll hand over to you, Carol.
Thank you, Anthony, and welcome everybody. I'll be talking about one of Poche's flagship programs, the Atlas Indigenous Primary Care Surveillance and Research Network. What is it and why do we need it? I too would like to acknowledge that I'm joining you from Darug country west of Sydney, where the traditional custodians cared for and continue to care for land and waterways, from the mouth of the Hawkesbury River all the way out west past the Blue Mountains. Get my little laser pointer here. And I admire their enduring connection to country and the incredible amount of knowledge they hold and pass on. I pay my respects to their ancestors and descendants and extend my respects to my Aboriginal and Torres Strait Islander colleagues at University of Queensland and others who are joining today. So this is a very new idea for me, actually, introducing myself personally. My name's Carol Hayek. Hayek is an Arabic word that means to weave, although I don't know any weavers in my family. It probably was in my ancestry somewhere. I'm an Australian-born Lebanese woman. I was born in the inner northern suburbs of Melbourne, where loads of migrant labourers lived and worked. And I grew up between the western suburbs of Sydney and two villages in northern Lebanon. This one here is my dad's village, and we grew up in this street, the end of this street here. And I often will describe my life in Lebanon as being the best years of my youth, because it was just a whole other way of existing in the world as a kid, where everybody knew who you were. I'm going to get emotional. And who you belonged to, and they were invested in your safety and in your future. And it was very different to the feeling of growing up in Australia, even though my family did really connect us to the communities, the Lebanese communities in Australia. But experiences like that make me grateful to be working in an organisation like Poche that centres culture and community, because I feel like I can bring my whole self to work, and I can learn a new way of doing my job. I started in Poche in November as the new manager of Atlas, and I work remotely because I only recently moved back to Sydney from Melbourne after 20 years of living and working there. And it was mainly to be close to my family. I had aunties in Melbourne, and I realised how important that role is, and I wanted to be that for my nieces and nephews, and sharing their joys and their challenges as they become young adults. I moved here with my partner Ivan, who I have to say is a very funny man, and my 13-year-old Kelpie Koba, who on the other hand is a very serious and complex character. Yeah. Professionally, I'm an epidemiologist, And although I'm relatively new to Atlas, I've known about it since its inception almost 8 years ago. And I understand its value because I've worked in the infectious diseases sector, specialising in the surveillance of bloodborne viruses and sexually transmissible infections for the last 16 years. So I'm going to tell you what I guess, Atlas from my perspective and what I've learned about it. So Atlas is a system of disease surveillance where a network of Aboriginal community-controlled health services lend their data to help manage STIs and BBVs in the Aboriginal and Torres Strait Islander communities that they serve. And it is an extraordinarily innovative and unique program that's community-led. There's nothing like it as far as I've seen in the world, and it's very highly technical. This artwork is our Atlas logo. It was created by Jordan Lovegrove, Ngarrindjeri graphic artist and designer. The centre represents us, Atlas, working with clinical hubs and sharing information back and forth together to have, and then sharing that across other clinics and sites around the country so we can have a wide-reaching impact on the communities around Australia. Just pause to have. All right. So this is an overview of what I'll be presenting today. Before I tell you about Atlas, I want to set the scene with a brief background on STIs and BBVs and how they are linked, I guess, and how they have emerged among Aboriginal and Torres Strait Islander populations. And then how surveillance and primary care, what their role is in responding to STIs and BBV epidemics, and specifically bring in the context of Aboriginal community-controlled health services and how we can use their data in the STI BBV response, followed by some details about Atlas and how it works and what it provides. So STIs and BBVs are associated with significant morbidity and mortality if they're left undiagnosed or untreated. So often, or most of the time, if you're infected with an STI or BBV, you won't immediately drop dead. It's not urgent, but it is the, I guess it's the long-term infection that can cause serious complications. They're very commonly acquired worldwide, with 1.2 million new infections occurring every day. And 50 to 90% of infections have no symptoms, depending on the infection type. So most STIs and BBVs will go undetected for a long time, leading to reproductive health issues, neurological, cardiovascular disease, liver cirrhosis, cancer, and premature death. So it's very important to find undiagnosed cases of STIs and BBVs. And in terms of their modes of transmission, there is a lot of overlap in terms of how they're acquired. So all of the STIs are passed on through sexual contact, obviously, some skin to skin, most through the exchange of bodily fluids during sex, and babies can also be infected during childbirth. In the case of syphilis, it can actually be passed on through the placenta and cause very serious outcomes for babies, including stillbirth. BBVs can also be passed on during pregnancy and breastfeeding, but they're most commonly passed on through blood-to-blood contact. HIV and hepatitis B are also sexually transmissible. Hepatitis C, not so much. It can be transmitted via sexual contact, but about 80% of hepatitis C is acquired through sharing contaminated injecting equipment. So this overlap in the modes of transmission means that people at risk of one STI or BBV can be at risk of others that are circulating in the community. And the fact that infections are often asymptomatic means ongoing community transmission, resulting in simultaneous and persistent epidemics and increased risk of co-infection for people. This is why STIs and BBVs are addressed collectively in public health. For example, a health promotion campaign of education and screening designed to interrupt the community transmission of HIV would also work to interrupt the community transmission of other STIs. So often the many strategies that are used to manage BBVs and STIs are integrated so that they're more efficiently managed. Many of the strategies depicted in this wheel would be used to address all STIs and BBVs. Where the approach differs is in the biomedical factors. So not all have vaccines or prophylaxis that can be used for prevention, and not all of them have treatment or can be cured. So it's important that public health initiatives are aligned very closely with clinical management of these infections. So this table shows the biomedical strategies for clinical management and how they differ for each disease. So for example, there is a vaccine for HPV and hepatitis B. There's pre and post exposure prophylaxis for HIV, but none of the others have biomedical prevention. In terms of testing, the bloodborne viruses are a little bit more invasive because they require blood tests compared to these ones that that we can have swabs or urine samples to diagnose them. And then STI treatments are also a little bit more straightforward because they're either oral or injected antibiotic versus the BBVs, which have long-term monitoring and drug regimens to manage them. So to eliminate STIs and BBV epidemics as public health threats, the WHO recommends delivering existing biomedical and harm reduction strategies within a care continuum. And a care continuum is a comprehensive series of services or service stages, I should say, that are disease specific. So in this case, it would be, or say, for example, we're talking about HIV, it would be HIV prevention, testing and diagnosis, treatment, and then chronic care, so continued retention in care to ensure that people are remain free of those long-term disease outcomes. So they're very disease specific, and people are guided through each stage, ideally starting at prevention. But if someone is already infected, then they would start at testing and diagnosis. And the aim is to keep people engaged and retained along all of the stages. So they're disease specific, so people can get the appropriate tests and treatment, but they also need to be person-centred, so they can be so people can be engaged in all of the care continuums that are relevant to them. And so if someone comes in for an STI screen, the approach would be to think about what are the other STIs and BBVs that people that person needs to be tested or treated for. Most STIs and BBVs are diagnosed and treated within primary care. Primary care providers are the first point of contact for routine care, and they can provide services along the entire care continuum, from prevention or preventive care and harm reduction to treatment and ongoing management. And part of that care continuum is if a primary care provider can't, for example, isn't licensed to provide HIV treatment, then part of that care continuum is linking them into treatment and then continuing that shared care. In Australia, we have been aiming for the elimination of STIs and BBVs as a public health threat since 2015. And to achieve that, there's been substantial government investment in universal access to all of the biomedical strategies to support the care continuum. So things like Medicare and pharmaceutical benefit scheme, for example, providing free testing and subsidised treatments and free vaccines. And this has really fast-tracked Australia's progress. However, nationally, collated data still show disparity in health access and outcomes for key populations, including Aboriginal and Torres Strait Islander people. These surveillance figures clearly show the disparity in the population rates of the STI infections, comparing the Aboriginal and Torres Strait Islander people to the non-Indigenous people. These data come from the Kirby Institute annual reports. So infectious syphilis, the infection rate among Aboriginal and Torres Strait Islander people is almost 5 times that of non-Indigenous. For chlamydia, it's twice that of non-Indigenous, and for gonorrhea, it's 4 times the rate compared to non-Indigenous. Similarly, for hepatitis C, there's a 6-time difference in the infection rate. And the HIV rates have been disaggregated to separate non-Indigenous group. So if you're just looking at Indigenous versus non-Indigenous, the 2.7 versus 2.9, it looks similar. But when you disaggregate by Australian-born versus overseas-born, you see that there is a disparity here as well. And this very clearly indicates barriers to healthcare, because there's 2 groups here experience increased stigma and discrimination in mainstream healthcare settings, and they experience other structural and social barriers to healthcare, and they're the groups with the highest rates of infection or HIV in a country that has maintained one of the lowest prevalences of HIV in the world. Sorry. Okay, so one reason is that the delivery of primary care cannot or does not always consider and address the social determinants of health that intersect with Aboriginality or other ethnicity. These individual determinants, some of them listed here, contribute to health disadvantage, which means that care and treatment for these individuals is more likely to be delayed and lead to disease progression and ongoing transmission, and therefore epidemics persist in communities where this is the case. And it's not only these individual health determinants that impact people's healthcare and outcomes, but much broader societal, structural and historic factors, mainly resulting from colonisation and racism, that cause greater inequities in the way people can receive healthcare. And this is where Aboriginal community-controlled health services come in. As well as being primary healthcare providers, they're addressing the health inequity experienced by Aboriginal and Torres Strait Islander communities, and of course understand that good health to Aboriginal and Torres Strait Islander people goes way beyond physical well-being. But here they sit in the health system, so they are the forefront, I guess, of healthcare delivery. But you can see they are, fighting a hell of a lot of barriers at the same time. There's plenty of evidence worldwide to support the idea that cultural safety and community-led approaches provide an enabling environment for effectively engaging and retaining people in the STI BBV care continuums. So this is an image from the Pan-Canadian framework for STI BBV action, and similarly with Indigenous populations around the world experiencing the same barriers or similar barriers. Aboriginal community-controlled health services provide a broad range of services to support clients through social factors like racism, housing and employment. And they function as community spaces through which Indigenous people attempt to deal community spaces through which Indigenous people can have their needs and underlying structural causes addressed So there are about 145 Australia-wide Aboriginal community controlled health services, most of which provide the primary healthcare service. They all provide culturally informed holistic healthcare, and they work directly or indirectly to address the social determinants of health for their Aboriginal and Torres Strait Islander clients. I just want to go back to the role of surveillance systems here. Disease surveillance is one of the core strategies that's used for guiding the response to epidemics, and it's an ongoing data collection, analysis and reporting of health events. And often medical records are used as a source of the health data, and the purpose of the surveillance is to provide information in a timely way to the people who need to know. And many sources of health data for surveillance and there are many sources of health data for surveillance, but what we need is very detailed data, because if we have detailed medical information about infections, we are able to better understand the characteristics of the people who are affected, and that way clinical and public health strategies can be tailored to reach more people in less time. And when we're able to use medical data from ACHs, for example, we're getting a real-world representation of how people are engaging with primary care services, and that data can then inform innovative approaches to service delivery programs by providing routine measurements of people's retention along the care continuum, enhancing access to BBV STI care. On that note, Atlas is an Aboriginal and Torres Strait Islander sentinel surveillance system, which means it is a network of primary care clinics who are participating and lending their data for the purpose of surveillance. It's a collaborative network of Aboriginal community controlled health services, and there's about 50 of them that are currently participating in the network, and each of them might have more than one clinical site that Atlas collects data from. And it uses the electronic medical records that are extracted directly from these ACHs clinics to monitor STI BBV testing, diagnosis, treatment and management. And that's the innovative part of Atlas, because electronic medical records are quite complex. They're digitised client records that are stored electronically at the clinic in their patient management system. And because they're collected for clinicians to provide care to individuals, they're not designed to be analysed and summarised the way we want to do it for public health or surveillance. They're incredibly complex because they are recording every single encounter with an individual at service. So they're complex in their structure and their content, and they contain highly sensitive and confidential information. And it's not, and these systems are not readily set up to share data. So there are a lot of technical layers to receiving and collating and analysing these data for ethical surveillance use. And the way it's done in Atlas is by using a software called Granite, which was developed at the University of Melbourne. And Granite can interface with various patient database software. So here are the ones that it currently can interface with. There's one missing, which is MMEX. And what it does is that it automates the selection of the actual information that we want to collect from the site, and it de-identifies that information and it securely transfers it from the patient EMRs to a secure databank, where we can then decrypt the information once we receive it. And it uses a privacy protecting technology to scrub the patient identifiers from the record before they leave the site. And this here demonstrates the, I suppose, technology that that's used, because once we get the extracted data, we want to be able to link an individual's records. So we want to be able to link their demographics, for example, to their test result. And so there needs to be a unique identifier within the patient record. And Granite uses a, industry standard, I guess, hasher that can use very basic identifiers from the clinical record and create a unique string that is irreversible outside of the clinic. Atlas is, I guess, a custodian of very sensitive information, and it needs to be accountable and responsive to the ACHs that are providing their healthcare for the purpose of improving the health of their clients. And so to do this ethically, Atlas has a strong focus on Indigenous data sovereignty and a strong governance arrangement that is led by communities. Atlas is governed by the Clinical Hubs Group, who provide Indigenous governance expertise. They will review any of the potential new information that we might want to extract, or new research proposals, or even any developments to Atlas itself. So they are very much guiding the direction of the program. And they ensure that Atlas is adhering to Aboriginal and Torres Strait Islander health research principles. So this slide gives you an idea of the breadth of information that Atlas is collecting. It's important to note that we don't access all of the patient's record. It's filtered to only information within the patient record that's related to STIs and BBVs. And so aside from the patient demographics, we get the type of provider, so whether they were seen by a nurse or psychologist or an Aboriginal health worker, the reason for visit, and so on. And then the test requested and the treatment requested, or the treatment prescribed, and the dates, and so on. So some of the data is structured and some of it is semi-structured, so it's short text. So it's a combination of structured and semi-structured data that we receive. From 2016 to now, there have been over 180,000 unique clients who've accessed a GP, Aboriginal health practitioner or nurse at health services in the network. And that together represents over 10 million visits to the services. The clients are a little bit above 50% female, and 35% are aged 15 to 30 years. So this is just a recap of how Atlas works. So once sites are engaged and agreements are in place, Granite is installed at the site on a computer, and then it weekly is able to extract the agreed upon data from there that's de-identified, and it's encrypted. So the encryption here that's used is the same sort of technology that's used for online banking, so it's quite secure. And then we decrypt it here at Poche, and then from here we're able to analyse the data to produce summaries that are useful to the sites themselves. And I want to stop and say it's an incredibly technical amount of, it's very technical work to wrangle clinical data into meaningful surveillance measures. There is a hell of a lot of work that goes into programming and automating the many levels of data cleaning, processing and analysing that goes into curating something like these reports. And so I guess I just want to honour that part of the system that is probably well behind the scenes. All right, so Atlas then provides services with both epidemiology reports or surveillance reports and a clinical dashboard that they can access. So every 6 months, the sites that are involved will receive a report that compares that 6 months to the previous 6 and 12 months, and then presents. There's actually 17 performance indicators in total, 7 of which are related to STIs. And these are all reported on in the report. And then 4 that are related to BBVs and 1 around HPV. And all of these indicators are designed and agreed upon by the governance groups and are aligned with the clinical guidelines. This is briefly what the dashboard looks like, and it pretty much gives sites or clinicians an overview of all of their data since 2016. The dashboard is interactive, so you can create customizable analyses, and it's a secure dashboard with site-specific data available to the site only. And you can use the filters and settings up here to observe the trends in demographics, in testing, diagnosis of each disease, and then you can disaggregate that by age group and gender, Aboriginality and time periods. So this is an example here, what you might see. And the nice thing about seeing changes over time is it can help clinics to monitor changes in their clinical practice that might have resulted in changes in outcomes. So it's a way of evaluating their own services. A recent feature is this infographic that can be accessed via the dashboard, and it summarises the indicators in a brief snapshot for whatever time period is selected. And a little bit about the way that services use Atlas. So Aboriginal health workers or GPs or nurses can access the dashboard to monitor progress towards service improvement goals. For example, increasing STI testing rates for pregnant women or increasing health service access for young men. Senior clinical staff can regularly review surveillance reports and dashboards to set service improvement goals and evaluate the effectiveness of those strategies, so a little bit more high level. For example, increasing adherence to clinical guidelines and informing decision-making and service planning. And then higher again is around using network comparisons for benchmarking, advocating for funding, using data to inform decision-making around resource allocation, and so on. So Atlas has the ability to evaluate new policies, clinical practices, or health promotion because it provides an ongoing consistent measure of service delivery and outcomes in the population and provides data around that to inform action, like which clients should be getting health messaging, for example. And surveillance systems are not one size fits all, and Atlas has this built-in, I guess, ability to respond to what clinical services need and what specific populations need. Based on a literature review that I completed last year, just searching globally for STI BBV surveillance systems that use EMR data, there were 6 in total that I found that extract data from clinical EMRs. And Atlas is unique in that it is the only one of these systems that's not based on data from clinics that specialise in STI and BBV care, like sexual health centres. And that gives Atlas more of a vision of what is happening on the ground in the communities they serve. It isn't biased towards people who are receiving those services. And it's also the only system that's community-led and providing data for continuous quality improvement at the clinical sites. So currently, Atlas provides national and local evidence of testing and positivity, STI and BBV testing trends 6 monthly. It is able to measure impact of strategies and clinical practice, and it's also able to measure specific issues or emerging issues in populations like positivity of syphilis in pregnancy. Currently, what we're working on is expanding Atlas so that we can more efficiently report on STIs and BBVs within Aboriginal health, what are they called? Aboriginal health assessments, the 715, that's the Medicare item number for that. So some guidelines, there are some guidelines around using that appointment as an opportunity for STI and BBV testing. And also we're expanding Atlas to include vaccine preventable diseases. And to do that, we need a very clear understanding of the vaccine coverage within these clinics. And so we have applied to link our data with the Australian Immunisation Register. And what we really want to do as well is be able to measure those care continuum stages, and they're called the cascades of care. So we want to be able to summarise client journeys through the care continuums for services in the future. This is the current Atlas team, led by James. Most of us are relatively new. Rani and Shelley have been managing the system for a year now. And I have to say it's a wonderful team to be a part of, because everybody really has a specific set of skills that they bring to Atlas. To there's a lot of moving parts, but together it's a pretty cohesive team. And I want to mention Padham Kebria, who is also on the team, but is on extended leave at the moment. I'd also like to acknowledge the previous team, Claire, led by Claire Bradley, and the analysts Kate, Paul, and Alan, who pretty much, set the system up from the ground. And special thanks, of course, to the Clinical Hubs reference group members, which have changed over the years, the ACHISs themselves, executive staff and clients, the investigator groups on the grants that fund Atlas, and I've listed them there. Thank you.
Terrific, thanks, Carol. We've got time for a few questions. Anyone online or in the room?
Yeah, I've got a couple.
Yeah.
Just Carol, is that Carol?
Yeah.
Hi, it's Mary.
Hi.
Just how are you? Well, just a couple of slides back, and it's got nothing to do with the STI and BBV, but it was the acknowledgements. So I think if you just a word of caution or advice, if you are going to list names, don't leave anybody out. Because that's then, is it misinformation? It's part. Well, Lauren actually facilitated a couple of the Atlas workshops.
Of course. Yeah, thank you, Auntie Mary.
Yeah.
Yes.
Yeah. We just things like that, and is it done a lot of work in terms of your presentation, and it's probably one of those areas that state government really don't overfund, or federal government don't overfund. They wait for an outbreak
Mm.
to the reactive approach as opposed to the continual comprehensive primary healthcare approach, which is maintaining, care and support and surveillance so that the local community can surveil, manage the STI and BBVs, on a regular basis so that they don't have to wait for the 715 health check as such, right?
Mm.
Yeah, so there's just some advice around that, but it's certainly in Queensland. I don't know whether it's a federal legislation, but there's a health equity and access strategy. Because I saw the map, and Queensland's a bit shy of purple dots or blue dots. Where
Purple. Yeah, where the sites were, where the actions. Mm.
Yeah, so certainly noticeable given Queenslander. Actually, we all are, but in terms of the growth, and maybe there have been challenges or cultural constraints or whatever in terms of why Queensland's the number it has. I don't know in terms of do you maintain the status quo or look to grow numbers too, right? Because just a thought in terms of the proactive preventative public health measures that you mentioned. Yeah, so just a few thoughts. I had others, but you know what would have been good too, Carol? If when you, and it might be a Poche thing, I don't know, when you do a seminar thing, yes, an opportunity for the audience to ask questions.
Mm.
As you're going through.
Oh, yeah. I actually do prefer that, but I worry about the time factor. But I do prefer the interaction for people to stop and ask questions, like to stop me and ask questions. Yeah.
I'll give you some advice. If it's your session, but it's something that you can control.
Thank you.
Hey, it's your session, but if you don't control your session and because the information you might be presenting, everybody in this room might be across it. On the other hand, everybody in this room might not understand or be interested in it. So it is people are here because they are interested. So is that, and I think one way of doing that is by giving people an opportunity to just a thought, eh? So I look forward to that.
Thanks.
Thank you.
Well, I'd love some questions.
Yes. Go on, you fella. Floor's open. Yeah. What's going on in the back row there?
Yeah.
Sure, Chris.
Carol, thank you very much for your presentation. Where's what's the future direction or forward planning for Atlas? It's been running for a little while now, but what's the future directions planned?
So I suppose there's two or maybe even three parts to that. So of course there's the scaling up. So we're talking about the technical aspect. There is plans for new ACHs to come on board. And as far as I understand, Atlas has actually grown in number quite quickly. So a big part of the work that we want to do is make sure that our technical methods and procedures are ready for that. The other is the increased scope of the actual diseases that Atlas is going to be monitoring and reporting on. So I mentioned the vaccine preventable stuff and the linkage to air. So Brielle, who I also didn't put up there, Auntie Mary, will be doing, so her PhD is around analysing some of that data to look at incidents of VPD infections among certain groups. Also, the MBS item numbers. So currently we're going to start with the 715 appointments. We're going to increase our detection of pregnancy through MBSI numbers. So it's really a lot of refinement of the data that we already have. Then there is the continuous quality improvement aspect. So last year there was a workshop run, for example, a lot of feedback about what sites would like to see and how we can work better with them to use, to present the data they need and for them to be able to use it, to meet their needs. So those are sort of the three key areas that it's developing in.
Thank you.
All right, Anthony, I have another question if anybody else wants to. This is a quick one. You can. Oh,
You go first.
It's just about the data. I think it's a slide before governments, and there was 7 or 8 current programs.
Indicators. Yeah.
Yeah, but the one that wasn't there was MMEX.
Oh, sorry. The software. Yeah.
Yeah. So the slide on.
Yeah.
I am aware that there are Aboriginal community controlled health services that do use MMEX. So I guess they're not eligible to be a part of the network, or what?
They are. Yeah, so they are. There's a few sites now that are on Atlas that use MMEX. So Granite has had to, I guess, make adjustments to be able to bring their data into Atlas. Yeah.
Okay. Well, you need to change your slide, or you mentioned that.
I do. That's a Granite slide, but we'll need to ask them to add it.
That's just a QA check. But
Yeah, thank you.
Yeah, you're welcome. Yeah.
Hi, Carol. Thank you for that information.
Hi.
It's Kelly here. I think, being here, you do know it, but it's nice to hear the inner workings of Atlas and the intricacies behind it. I'm just wondering, with the 715 health check and then that future direction, are there going to be amendments made to the health check, or is it up to each individual health service then to just really reinforce that when they're conducting health checks?
Yeah, so it's not, so all we can do is facilitate their work really by reporting the data that comes from them. So if they are wanting to provide some clinical, some sort of clinical change around the 715s, then we just need to make sure that we can detect that in the data that we're reporting to them. So it's just we have to sort of closely collaborate on how that will be analysed and sent back to them.
Often I think
and
in
what
the
their
health
intentions
checks,
are. Sorry?
Often I think in the health checks, the information, the data you probably collect is only as good as the information provided, and potentially looking at why people go and get health checks. I know coming from my research in Inala, it's to play football, it's to get, deadly choices shirts.
Yeah.
So it'd be interesting how quite closely you work to be able to use that, in the data.
Yeah, context is so important, Kelly, and it's difficult for us if we're just looking at the data to actually make sense of it without the engagement and feedback from the services themselves. Yeah.
Thanks.
Did anyone online have a question? None in the chat. Any other questions? I just had one about how, Carol, and I appreciate you're relatively new to Atlas, but how
Rani and Shelley are here, they might be able to.
Yeah, I'm just really interested in how comfortable the services are with the data security arrangements. Like, are new services, is it something that they're quite anxious about when they are considering signing up to Atlas?
Maybe Shelley and Rani are better placed to answer the question because they've actually been through those processes with sites. But I imagine that once they are participating, then those anxieties, I guess, and those questions and concerns have been addressed. But Shelley, you might want to say something about that.
Yeah, I guess I'll just reiterate what you've just said, Carol. That's absolutely true. There certainly some services are more concerned than others. We always talk about what kind of those technical and security processes that occur behind the scenes and that Granite implements and that that their data is de-identified at the site, and we don't ever see that. So, and that it's, you know, it's brought to UQ in a convoy, as Alan once described it. So, an armoured convoy. So it's well protected. But yeah, so certainly some archos have been have really interrogated that process, and we've had to definitely describe that in detail in the past, but they've all still come on board. So yeah, so I guess we're confident about that security, and I guess they become confident in time.
And Granite's been around for a while, I think 2010 or something like that, and over the years have developed and refined their processes too. So there's, yeah, so I suppose it's only strengthened over time.
Yeah.
So they involved in any other public health surveillance measures?
Granite? Yeah, they are. Yeah.
BG?
Several. So Access, which is a very similar system, STI and BBV surveillance system that's been running since 2012. They have a general practice data repository at the University of Melbourne that Granite extracts data into. They've also done a national diabetes study using Granite, and they've also done government data linkage using Granite. So it's, yeah, it's getting a strong reputation in the sector. Yeah.
Thanks, Carol. Sorry, Anthony, but there is one question that as you're going through the slides that made me think, I wonder. So the contractual agreements, who's that in terms of the services and Atlas, who's it signed off by? Who's the key signatory within the service?
Shelley or...
Never mind.
Sorry, the key signatory for the partnership agreements, is that what, participation agreements? The CEOs of the organisation, once they've agreed to come on board under particular circumstances, which they have the leeway to dictate as well if they're not happy with the standard participation agreement, and quite reasonably so. And I think it goes to our contracts department for them to sign for UQ. So the exact signatory, I can't tell you off the top of my head.
Right. Just thank you, Shelley. So CEOs come and CEOs go. In terms of continuity of the etc.
Yeah, and as far as I'm aware, they're revisited. The contracts are reviewed.
By?
As in, is that right, Rani? There's a time period on them, and then the service will have to re-engage and re-sign.
Yeah, so if they're expiring, we reach back out to the service, but also we have key contacts at the service and we get notified if they do change.
Right.
And then reach out and have another meeting.
So and another signatory, the current.
Yeah, another signature on the agreements, but also just a meeting about Atlas.
Right. Thank you. So I think, Carol, that would be a good inclusion around the practical the application around, the signatory along with the software for issues. Somebody's put the process in place. Who did identify and actually, implemented that because there's always a plan B. You always need a plan B. And it's certainly good to hear that it's ongoing. I think the capacity for, when the CEOs go or things happen, the program will still continue. So that's probably, other programs to learn from that in terms of contractual stuff. The other thing is the data stuff too. Who actually owns the data? Who owns the data?
So the agreements say that the the sites own the data. I imagine it goes further than that, and the individuals themselves own their own data, but we certainly don't.
Right.
So if a
Yeah.
site doesn't want to participate, they can tell us what they'd like us to do with their data.
See all that data you presented on the, this is definitely the last question, everybody. See that data then you presented in your session, Carol, that data, you said belongs to the services? So you would have got permission?
So the
Sure.
data that I presented was dummy data, wasn't real.
Oh,
It was just to demonstrate the
what do you call it?
dummy data.
Yeah. Wow. Well, you guess you learned something new.
I probably should mention that too in the presentation.
Yes, and
that it's
but
not
then
real.
and then you need to go further and say, well, it's not real. But you know, so if something, well, you are doing a good job. How do I know you're doing a good job? Well, you know, but then I was curious about the data in terms of the medical services and the clients on the you know, clients at the services who are, you know, I think today.
It's their data essentially.
Yes, well,
It is, yeah.
yeah, sorry. All right. Well, I've had enough, Ethan.
Carol, can I ask you a question?
Thank you.
Is there any relationship between the e-health records data that the services can access, and does any of that data then get put through to Granite?
No, so that would be going through another channel, and we don't access that data exactly. It is a completely separate extraction for Atlas. And the reason being is because it needs to be very specific about, you know, what's been tested for, what's been diagnosed, what's been prescribed, you know, and just around the STI BBV, whereas the e-health records might have more broad data in there.
Thank you.
All right, well, I'm just conscious we're at time, so we might end it there. And I'm sure if anyone's got any other burning questions, Carol, they can get in touch.
Yeah, of course. Thank you for the questions and the interest and the engagement.
All right, terrific. Thanks, everyone, and see you today.
Thank you. Bye.